Sorry.
No, it's tricky when we're talking about the weather, as probably everyone can expect here in the room. Talking about prior storm damage and anticipating the next round of storm damage. But wanted to get us started, I was just checking, and I think we have close to a full complement of members. I know Heather Perot from DAFS wasn't able to make it today. Representative Graham, not surprisingly, I think probably tied up. So otherwise, we have all of our members present either here in the room or online. And a lot to cover today.
Hey everyone, I'm hoping you can hear me on here. We just had the TV screen in the room that we're in turn off on us. So we're just trying to figure out how to fix that right now. So please just bear with us for a couple minutes and we will get right back to you hopefully.
It's the work.
Unfortunately. Okay, hi everyone. Sorry about that. Hoping you can hear and see us okay. Something happened and the whole system restarted here. So apologies again. I was starting to say we have a lot to cover, so I wanted to dive right in. So unfortunate delay, but I won't hold us up too much longer. I just wanted to briefly say we wanted to organize this meeting around hearing and learning a little bit from what's happening in other states as a way to start transitioning us from, not away from, but to include more of an eye on policy interventions and problems to solve after several meetings where I think we've been talking a lot about defining issues and research agenda, especially quantitative research. So that's the purpose of today's meeting. Very briefly, just wanted to kind of reiterate that I'm hoping we don't need to approach this, and certainly the way I'm approaching this is not as looking at a menu of policy options from other states and saying, let's pick a few and do them here. The idea is really just learning from the processes that other states have used, give some inspiration. You know, there may be ideas where we say, oh, there's the kernel of something there that we'd like to explore more. Exactly, yeah. So just wanted to see that as a foundational piece. And Maureen Hensley-Quinn from NASHP has very generously and kindly shared some time to come and join us. As I'm sure you all know, NASHP does so much work across states, collating information and sharing it and providing forums for us to get together and learn from each other. So I thought that they would be a great resource and that Maureen would be a wonderful person to kind of give us a high level overview and help to organize some of this complicated thinking. So I will pause there and hand it off to you, Maureen, to get us started.
Thank you so much for including me. And the task in front of you is big, so I really appreciate everybody coming together to meet and have these discussions. I will tell you, I was going sort of back and forth about the best way to approach this, and I'm sure there's another way, but I'm just going to talk to you a little bit about some of the work that we've been doing because states are approaching us with requests for assistance as they're diving in to figure out what healthcare affordability means to them and how they're approaching it. So I'm also happy to share some of this information as follow-up too. So I'll start with NASHP is a nonprofit, nonpartisan organization with offices right here in Maine, as well as Washington, D.C. We have staff actually across the country. My team works on coverage, cost, and value. And so that's why I'm here today. We work with states on all of those things. And by that, it's truly that we work with state officials across the country on Medicaid, children's health insurance, the state-based marketplaces. We do some work with departments of insurance, commercial and covered insurance. Cost issues predominantly are related to prescription drug costs, hospital and health system costs. That's because states have asked us to focus on those areas. And then in the past, I'd say year and a half, we've been spending a lot of time on payment and delivery system reforms, and in so doing that, looking at states that want to transform their health system to better, to work in a way that they feel would better maximize health outcomes. And truly the states we're working with have identified that they want to move away from paying for care on a fee-for-service basis, move towards capitated or global payments. That's both to hospitals, but some states are looking to do so in a region of their state, statewide. To date, the only state that is successfully doing that really is Maryland, and they're doing it focused on in and outpatient hospital services. But in having these conversations about paying on a more capitated basis for hospital care, there is a lot of interest in increasing payments for primary care and other community-based settings, again, with the goal of transforming the health system to really focus on health outcomes. So this is the frame that I'm coming from to give you this sort of update and to give you sort of a sense of what different states are doing. As we talk about affordability, whether that's internal to NASHP or external with states, we always start with affordability for whom. So are we talking about the consumer? Are we talking about the system? And within the system, are we talking about the state as a payer? Are we talking about commercial payers, employers? Are we talking about everyone? And so I just share that because different states are coming at this with different goals, and different state programs are coming at this with different objectives. So I will start by sharing a lot of recent focus on our coverage work, really stemming from what the state-based marketplaces have been focused on, is trying to ensure consumers do not have a financial barrier to accessing care. And so that's what's been driving some of their decision-making, policy-making. They've been focused on ensuring that consumers have little to no cost sharing. And in order to do that, recognizing that the healthcare market is complicated, they are focusing, many of them, on specific areas. So I'll highlight Massachusetts, and then other states are following. California is following, DC, others. Massachusetts has identified that one of the cost drivers in their state are individuals who have chronic illnesses, and they've named those illnesses to be diabetes and cardiovascular disease as consumers that are foregoing care because of how expensive the care is to access. And when I say care, I mean provider appointments, I mean drug and other supplies to manage their chronic illnesses. And so through the state-based marketplace, they are working with health plans to design those plans so that individuals do not have to work through their deductible before they get access to services that fall within those areas. So there are plans that are for sale on the marketplace that individuals can buy where there is zero cost sharing for anything related to diabetes or cardiovascular health issues. There are other states that are choosing other illnesses and focused on other areas, but the state-based marketplaces are increasingly looking to use plan design to help individuals access care without having a financial burden for that care. So that's one area and one way that states are sort of leveraging their purchasing power, and not all state-based marketplaces are able to do this level of plan design. So there would have to be some policy making that would help effectuate that. So then the other issue where this comes up quite a bit is in prescription drug costs. Are we talking about trying to help people pay for their prescription drugs at low cost to the consumer? Or are we trying to help the system better pay for expensive drugs? States are coming down and doing both, I would say, right now. So we're learning a lot more about copay caps. I know there are copay caps for insulin. Some other states are looking possibly to do it in other places. Insulin has been the primary focus to date. There are states that are taking more, I would call it, innovative approaches and using prescription drug review boards to identify high cost, highly utilized drugs and doing an analysis to understand if those drugs are affordable or not. One state that's gotten a lot of press lately because they are sort of further out ahead than many others is Colorado. Colorado does have a prescription drug copay cap, but they are also leveraging their pharmacy prescription drug review board to focus on the patient experience for accessing the drugs that they've identified. They have been reviewing their top 5 drugs. To date, I believe they've reviewed 3 for affordability purposes, and now they have named 1 as being unaffordable to consumers, and they are now pursuing internally a plan through regulation and rules to set an upper payment limit. So from NASHB's viewpoint, that is a policy and a practice that does affect the end consumer, but also looks at what that means for the overall system as well. Then we also have a number of policies and a number of states that are using them to address high and rising hospital and health system costs. But I will share the predominant focus right now for states that are looking to address high and rising hospital and health system costs really is consolidation. States are trying to better understand ownership and different responsibilities that different members of the health system have for hospitals and providers to understand some of the underlying issues that might be driving high costs. And so while there are some states that have pursued some level of addressing price, primarily it really has been focused on better understanding the system and then finding cost issues within it. I will name one area that states continue to ask us about, but there has been limited uptake, but it is Medicare reference-based pricing. There are some states that are actively pursuing that right now. And we point to Oregon's state employee health plan as being the state that has implemented it the longest and continues to use that policy. And they have published their studies that show that it has had savings for their state employee health plans. It has not to date had an effect on access to providers that they want their state employees to be able to use. I will just highlight two states in particular that are looking, and there are more, but just for an example, we're working really closely with Colorado. So I named some of the things they're doing on prescription drug pricing. On hospital and health system side, they are also leveraging their Department of Insurance to use their rate review to encourage health plans to address high hospital inpatient and outpatient spending. They have a law that asks the health plans to reduce what they're paying, to reduce premiums for consumers by 15% over a 4-year period. And they're doing this in an incremental way. So last year was the first year that they asked health plans to reduce premiums by 5%. And they're very directive in how they expect those reductions to happen. They want health plans to renegotiate contracts with hospitals and pay their hospitals a lower rate. This year, they are looking to have that reduction be 10%. And the reduction is off of a baseline, I believe, of 2019 or 2020 of what consumers were paying for their premiums. So now we don't know the end result yet. There is data being collected right now to understand what the premium rates will be for the next plan year, to understand if they have been able to reduce by 10% off of the baseline year. And if they do not achieve this, they will have public hearings to understand what is causing that increase. And then ultimately by next year, they hope to reduce by 15%. So we look at Colorado as a state that's trying to do things for the system and for consumers on both prescription drug costs, hospital and health system costs. And then they also have efforts related to a delivery system transformation. So they have signed on to participate in the federal Making Care primary model, in which they are going to be leveraging, Medicare is going to be doing this along with Medicaid. They hope to get private payers as well to incentivize payments being made to primary care and behavioral health providers. So Colorado, we sort of put in a bucket of trying to do this with the end consumer in mind, but paying attention to the whole health system. They also have a Colorado option that is being sold on the exchange, their marketplace, to help consumers get lower priced care. Then we have Oregon. Oregon is also taking a pretty comprehensive approach. They have a cost growth benchmark where they are collecting information, and they have established an infrastructure to set a benchmark for overall total expenditures of care every year. Within that, they also are unique because they have an enforcement mechanism where they could fine or ask for fees from entities within the system that don't meet the benchmark. They have not put that into use yet, but it is available to them if they need it. And I will say that enforcement mechanism comes after multiple years of not hitting the benchmark. It's not the first year, it's I believe 2 years, and they assess that over a time period with some analysis about what's causing the entity to go above the benchmark. So they have the benchmark. They are using that to identify some prescription drug pricing issues. They do also have a pharmacy, a PDAB, a Prescription Drug Affordability Review Board. They do not have the authority yet to set an upper payment limit, but they are reviewing the affordability of highly utilized and expensive drugs. They are making their assessments public, and they do have a plan to seek authority to be able to set an upper payment limit, but they don't have it yet. They are also a state that has a long history of leveraging delivery and payment reform. They use a regional approach to pay for services through Medicaid. They are trying to explore whether those regional care coordinated organizations could be broadened to approach a more capitated model for payment, not just for hospitals, but overall. They do have an overarching plan to move away from fee-for-service. They are taking a thoughtful approach to moving in that direction. And then they also have increased health market oversight, where they are trying to explore the different ownership transactions and other things within their market so that they can identify when partnerships or purchases or affiliations across those in the market could possibly increase costs, could have an effect on health equity, what that will do to access. It's not just a cost mechanism, it's also to promote increased health equity and access. With that, I think I'll stop and see if there are immediate questions or if I could provide more information.
I have a question on the PDAB upper price limit for drugs. You know, Maine tried to pursue a similar strategy here, but you can't tell the manufacturers what to sell the drugs for. So if you're an employer and there's an upper price limit, you can either comply with the law and not offer the drug because you can't buy it for that price, or you can break the law and pay what the manufacturer wants to charge you for. Have states figured out how to get around this and get at the actual manufacturer price setting?
So I'll note that the way the law is constructed, it actually doesn't set a price. It sets a payment. So the state has the authority by setting an upper payment limit to say all fully insured entities in the state would pay X amount for that particular drug. So they really don't have the authority to set price, but can sort of set a payment limit. What we've heard is that from the employer perspective, there are employers that are some frustrated that because they're not in a fully insured plan, they might not benefit from this, but there is an opt-in for those with self-insured plans. And then so to date, this hasn't been done yet. So I can't say like this is the silver bullet or this isn't the silver bullet. We actually don't believe that there is going to be an instance where a drug manufacturer simply takes the drug off the market. It would be very challenging to do that, and there aren't a whole lot of incentives to take a drug right out of the market rather than continue to provide that drug. There's other things that manufacturers are doing that they might stop doing. For instance, they may stop providing consumer assistance. We know there's some support for that, but with the upper payment limit, the hope is consumers wouldn't need that same level of assistance. So we're watching everything very carefully. We're supporting these states and trying to make these decisions, but they are not made lightly. But I do just want to underscore, it's not the price they're setting, it's payment.
Great, that's very helpful. Thank you.
Okay, cool. Just briefly add one thing to this, and all credit goes to NASHP for this information, because I was just talking with Jennifer Reck in preparation for one of our PDAB meetings. But just to flag, Colorado, as Maureen mentioned, is definitely a leader on this and has selected a few drugs for upper price limits, and I think is on a timeline thinking about 25 for implementation, is undergoing some rulemaking now. So I think we are watching to see a state sort of move into the implementation phase of those and how it impacts the market, how much there is sort of movement up the supply chain when there's that price or that payment cap, excuse me.
Do you feel like this is actually going to have an impact on total cost of care, or is it just going to shift basically who's paying the cost? So you're taking dollars, off the patient's plate and putting them on the employer's plate that then shows up in premium increases beyond what trend would be. How do you think about that?
Yeah, and again, credit to Colorado. This is being done through Colorado. They have a specific office within their Department of Insurance. Their Department of Insurance, in choosing the drugs that they're doing a review for, have spoken with health plans to identify some of the top drugs that they see driving their premium increases. So the goal is to identify drugs, set an upper payment limit to limit the payment that hopefully then will bring down some of the premiums. And they're doing this, again, a lot's happening in Colorado where I don't have all of the insights to, but they've shared with us that they really do hope some of these drugs that they've chosen are drugs that if you reduce what health plans have to pay, that it will reflect in a reduction of premiums. And they are also trying to think through, and this is multiple states, not just Colorado, in going through this exercise, which takes significant resources, is there a way to ensure, rather than just hope the premiums come down, is there a way to ensure that consumers do see not just a point of sale reduction, which is the goal, but also a reduction overall to the health system? There is some thinking around leveraging plan design, like the state-based marketplaces are doing, to provide some level of $0 upfront cost, but then have that reflected in premiums as well as you set the payment limit. So there's lots of different discussions going on, but I'll just note that your questions are great questions and ones that states are wrestling with right now.
And we have Colin Bio from New Mexico joining us just for 30 minutes. So I don't want to cut off this discussion, but I think Maureen's able to stick around with us so we can go turn. But want to jump to Colin just because he had this 30-minute window and want to maximize his time. Trish, I saw your hand up too, so I will make a note and we will return to you when we get back to Q&A at 3:30. Colin, I'm hoping, that you can hear us. Hi, welcome virtually to Maine.
Hello, are you all able to hear me?
Yep, we can.
Okay, great. Thank you so much for inviting me to participate today.
Yeah, thank you so much for joining. Know how much everyone has going on, although I know New Mexico has a short session than us, so I think that you guys have adjourned, but I'm sure you have plenty on your plate. In light of the time, Colin, if it's okay with you, I think we can bypass introductions, but we'll just ask if folks are asking questions, if you can just sort of introduce yourself so Colin has a sense of your background. Before chiming in. And Colin, I did share, as I mentioned, some pre-reading. So I think unless you'd like to jump in and sort of give a lay of the land, I thought maybe I could start off with some questions for you and then let folks sort of jump in and ask about what they've been learning.
Yeah, that sounds great.
Wonderful. My first question, and it's a good segue from Maureen's presentation, was, that we're trying to grapple in this group with different dimensions of affordability, asking ourselves about really the consumer level versus overall sort of system costs and the differential impacts of those. And I know that this is work that in New Mexico, you guys have been engaging with on a lot of different levels for many years. So I was hoping you could kind of just share with us how you've approached that, if there's different quantitative or qualitative kind of processes that you've gone through that have helped you to kind of define affordability in your state and think about setting priorities.
Sure. Yeah. And, I'd say at a state level overall, there's quite a few things that are happening in the state. Kind of one of the biggest ones has been we've kind of created a new agency that we call our healthcare authority that's sort of consolidating a lot of the different health purchasing programs. And I think that that's trying to get at some of those systemic costs. Our legislature has been doing quite a bit of research in the area of cost drivers. We've looked at global budgeting, started I think following in your all's footsteps on some of the drug price transparency work. So a lot of that winds up getting driven either through legislative interest or the governor's office. So I work for our insurance department. And so our angle on this kind of winds up getting narrowed down through that. So we helped in the creation of a healthcare affordability fund a few years back, and we were really active in highlighting that there was a big gap in potential for our health insurance marketplace. Our enrollment was remaining kind of well below the number of people that were eligible. And so we really, advocated for there being some of the funding going towards those programs, recognizing that because we have so many uninsured people who qualify for out-of-pocket costs and cost sharing reductions and federal premium assistance, that there was a real opportunity to try to use affordability as a mechanism to drive more enrollment there. So that in some ways that kind of helped us to narrow that down. We did a lot of modeling on like how many people are in that coverage gap where they might qualify for a program but aren't signing up, and then a bunch of follow-up kind of survey research on why they remain uninsured, and it, we had our predictions about that, but affordability definitely came to the top. And then we follow a lot of the research that's being done at the national level. There's a lot going on in health affairs and those sorts of publications that are kind of showing that, particularly in the marketplace setting, small premiums can really have a big impact on whether lower income people can sign up for coverage. So we've been really focused on how we design our programs to do that. We also are always kind of thinking about return on investment when we're developing the program. So where there's federal dollars that can be leveraged, or even the tax credits on the marketplace, thinking about, well, how much more would we have to put in to really get more, like driving more enrollment there, and thinking about how that really can help low income consumers the most, and how we can just stretch our dollars further that way. We did do quite a bit of stakeholder engagement in the development of the programs. I think the most valuable thing was really trying to hear directly from consumers that aren't necessarily like somebody that we would be able to like see at the Roundhouse or something like that. People who didn't really necessarily know the policy issues that like we typically are working in, but that real life experience of like what was most frustrating for them. And that's where we got a ton of feedback about the frustration with out-of-pocket costs, and part of why we kind of really focused a lot of energy there, because it does just become such a huge source of frustration. So we had to do a lot of that, direct engagement with stakeholders, and then directly with the consumers. And a lot of the stakeholder process that we did was really focused on like, how do we operationalize the policies that we're developing to meet those consumer concerns. And so that really helped us with kind of the technical aspects of making sure that like actually delivering on what those consumers were asking for was feasible for the carriers and the providers. So there's that. Focus groups tend to be something that has been really helpful for us, both in terms of just getting that direct feedback, but also shaping how we talk about the programs and maybe address things that we wouldn't have intuitively thought were going to be something that might be a concern that people had about a program. So those have kind of been our main ways of developing policy and trying to get input on the different programs and sort of inform how we're thinking about affordability.
That is super helpful. Thanks. I'd love it if you wouldn't mind maybe sharing a little bit more about like the survey and focus group process, if that's something where you engaged with, national organizations or had support, because I think that's really interesting to us. I mean, we've done some of the similar data analysis and we see these populations of people who remain uninsured despite being eligible, but I think kind of figuring out who they are and why that's the case has been a struggle. So we'd love to just maybe learn a little bit more detail about that process.
Yeah, sure. So some of the survey data we were using was conducted by like consumer advocacy groups in the state. And so we were able to rely on that. And they were asking a lot of those practical questions about challenges with affordability. We did a follow-up in 2023, 2023 about both, it was kind of focused on other topics that were happening at the time, including the Medicaid unwinding, but really trying to drill down into some of the more specific issues that people are facing when it comes to affordability and how they would define it. And so it did help us to be able to have all that data at our fingertips so that we could do our own analysis and really look at like what are the key demographic features that we're hearing these things from, and where we are part of the market that's being regulated, where they're currently getting their coverage or where they might be eligible for it. And then we both Office of Superintendent of Insurance, as well as our Human Services Department, have on a number of occasions contracted with the Urban Institute to really do a deep dive into using their microsimulation model into what those demographics of this uninsured population are, so that we're using that to inform how we form focus groups, right? So we want to find people who are representative of the population that we're having the hardest time reaching, and then try to really dig down in those focus group discussions about what those key barriers to getting coverage are. And a lot of it, from what we found, really was perceptions of affordability often get in the way of people even taking that first step to check the marketplace. And there are some instances where people go to the marketplace and look around and they say, I don't think I can afford this. Luckily now with our programs, hopefully that's happening less and less. We've seen enrollment jump pretty significantly since we both started these programs, but also since the Medicaid unwinding was completed. So it's still a process that we're kind of always refining. We've been working with some outside consultants on setting those up. And then, of course, our marketplace is always a partner in doing that as well.
Very cool. Definitely something aspirational. And as a group, I think a little bit later, want to start talking about a more structured way to get that kind of patient input. I'm going to keep on asking questions, but if anyone else has any, please raise your hand. I'll print it off. Yep.
Can I just ask, is New Mexico a Medicaid expansion state?
Yes.
So what percentage of your population is uninsured at this point?
Right now, it's a little bit in flux because of the unwinding. We don't have the most up to date, but we're somewhere between 8 and 10% uninsured.
All right, thanks.
I've got a follow-up one since you were starting to talk about the impact of the marketplace affordability programs. In hearing about them as you guys were sort of rolling that policy out and reviewing them again just recently in prep for this meeting, I do think one of the most interesting things is the structure of your turquoise plan program, really different than just layering on a specific additional state subsidy. So I was wondering if you could tell us a little bit about the policy development for that, kind of how you weighed maybe subsidizing premiums, which can encourage more enrollment versus, I guess if you saw an impact from that on the cost sharing reduction side, and also the dynamic of applying cost sharing reductions to gold plans as opposed to the silver. And I should say CSR, sorry, the state premium assistance, but utilizing gold plans as part of that, because I think that's a pretty innovative policy and maybe one that we could learn from.
Yeah, for sure. So this is where I can tend to get a little wonky. So Meg, stop me if you need me to like explain something a little bit more. But kind of early on, one of our goals was that we didn't want consumers to have to sacrifice premium affordability for out-of-pocket affordability. And we really wanted to make the choices that were available the best, like we wanted those to have the best financial protection and make those the kind of the most compelling options for consumers. So we do have a premium assistance program and a state out-of-pocket assistance program. And what we were really trying to do was like align those incentives to produce the outcome. And we just got some data back that does show that it's working. So I can talk a little bit about some of the outcomes after, but kind of the starting point for why we decided to apply our out-of-pocket assistance in some instances to gold has to do with some things that happened before the program was even under development. So the folks on the call might remember that in October of 2017, the Trump administration announced that it was no longer going to be making cost sharing reduction payments to issuers anymore. And this is the federal CSR program for lower income consumers. And the issue really was that issuers, our carriers on the marketplace, were still required under federal law to offer that CSR benefit without getting reimbursed by the federal government. So that obviously created a huge issue for the carriers. It created solvency concerns. It was like it happened right before open enrollment. It was a big mess. And so the long story short is the policy response, which most states would call silver loading, wound up having the effect of reducing the net cost of bronze and gold plans because those federal subsidies went up in response to that policy decision. So OSI actually, before we rolled out these programs, kind of got a head start on some of them because we actually formally established the amount that carriers had to apply to the silver plans in what we call a CSR defunding adjustment. And essentially what that did was it normalized that trend of gold plans being less expensive than silver plans. And so for those consumers who didn't qualify for really generous cost sharing reductions under like the federal ones, that gold plan wound up making a lot of sense because it costs less to enroll in that type of coverage than in silver, but then it offered better out-of-pocket cost protection than the bronze plans. And so we saw a lot of growth in gold plan enrollment in 2022 because of that policy change. And then as we were thinking about these dynamics and wanting to maintain that incentive for those who didn't qualify for the generous CSRs, really those over 200%, how we maintain that affordability on the premium side for them. We wanted to continue them to enroll in gold. And so we thought that the best way to align those incentives would be to apply our state financed out-of-pocket assistance to gold while kind of building on the federal CSRs on the other side. And we kind of had a win-win because of that. Like I said, those consumer premiums would remain lower, but it also meant that we didn't have to pay as much because we no longer had to subsidize the difference between a silver plan and a platinum plan. Instead, we were beginning with a gold plan. We only had to subsidize the difference between the two. So in terms of just stretching our dollars further, it wound up making a lot more sense to do it this way. It did, though, create complexity for consumers. It used to be the case that for you could just say enroll in a silver plan, you can get the CSR. A lot of people didn't know what the CSRs were before. And so, it was more of a technical term. And so we wanted to actually just completely rebrand anything that a state subsidy was applying to, or I should say the out-of-pocket subsidy is applying to. And so we decided to call those plans turquoise plans so that the consumer didn't have to be thinking about, oh, should I, be in gold or silver? When does it apply? At what income? Instead, the system kind of does that work for them. And then we do a little bit of local branding. And so turquoise was kind of our way of helping people make that decision while also having something that would be easier to kind of put out there as a New Mexico specific thing.
Very cool. Yeah, I always love, obviously we have to grapple with a lot of like hard cost issues and many that, have big price tags attached, and sometimes like those little tweaks to just presentation and shopping experience can be so meaningful. So I think that's a fascinating approach. I see that Renee, you have your hand up online, so I want to hand it over to you.
Yeah, thank you. Yeah, my question is about, so these plans, are they affordable, on a monthly basis, and then really high deductibles and, no cost, no coverage of medications, or sort of in addition to the premium, what is the affordability for the patient who then actually is trying to get care? Because I'm a primary care doc, and I see a lot of folks with the cheapest marketplace plan deferring a lot of care because of high deductibles and meds aren't covered and things like that. So I'm wondering if what it's like where you are.
Yeah, and I'd be happy to share with Meg some of the like plan designs so that you can see what these look like. So we were specifically trying to address that problem, right? When like lower income people are very price sensitive and oftentimes would opt for like a bronze plan that had a really high deductible and out-of-pocket max that would be a huge percentage of the person's income. So what these actually do, these out-of-pocket subsidies that we provide, is directly lower the co-pays, the deductibles, the out-of-pocket maximums that are available. And I'll just give an example. This year, we've got a plan for the lowest income group that has an out-of-pocket maximum of $200. The deductible is $0. The co-pays for primary care on some of the plans are $0. I think they only go up as high as $5 or $10 for that population. So it's all set based on income. As your income goes up, you're expected to pay a little bit more, but we really wanted to lower those barriers to care. And then this did dovetail with us also implementing our version of standardized health plans. And in designing those, we really tried to move away from a deductible applying to a lot of different services and really target that more at high cost services, and really move away from co-insurance where when you're getting the care, you're not exactly sure what the cost is going to be, and instead to co-pays so that you would know going in if you're going to get primary care services, it's going to just be a $5 flat fee. So we're kind of trying to dovetail that as part of this program as well.
Perfect. Yeah, and I can just sort of add, certainly anecdotally from my time at our marketplace, I think the existing federal cost sharing reduction program, for folks here, I think 138 to 150% of FPL, they may look at those and the cost sharing is very meaningfully low. I think it does taper out over time, but especially getting up towards 200% of poverty level and above, those are still folks who do not have a lot of money in their budget for healthcare costs. And we definitely had the feedback that cost sharing for them was prohibitive at times. So what New Mexico's done is kind of increase that generosity up the scale to kind of bring out-of-pocket costs down for a wider range, I think, of their population.
And if I could, I might have missed this, but how are you funding the subsidies?
So our funding source for this is something that came about in 2021. It was right when the federal fee on health insurers that was part of the ACA was going away. Our state stepped in and continued collecting that at the state level, and then used it to both put into this program as well as our small business subsidies and uninsured programs.
And that applies to fully insured products, is that right, in Mexico?
That's right, yeah, fully insured products, and then we have Medicaid MCOs, so it applies to those as well.
Sorry,
Yeah, how does it work with the greater cost sharing, benefits in terms of meeting like AV requirements?
Yeah, so we kind of set it up similarly to how the federal government does it, but if you're under 150% FPL, it's a 99% actuarial value plan. If you're between 150 and 200, it's a 95% actuarial value plan. And then starting next year, it's going to be between 200 and 400% FPL. It's a 90% actuarial value plan.
Is it, are you?
Like, I guess I'm just thinking like
the base plan meets federal requirements for AV to be a
Right.
gold plan, but then a subsidy is layered on top of it. So it's
Yeah.
not so, is that right, Colin? I think that's what.
Yeah,
like,
exactly,
not
yeah.
the federal AV require, right? Like, but you're still able to offer on the marketplace even though it's outside those parameters.
Right, yeah. So the way our system works is that if somebody had previously qualified for a 94% AV plan, we would actually replace that variant with this one. So during the shopping experience, that's the one that would be presented to the consumer.
I mean, very wonky. I'm like, we can follow up on that.
Yeah, me too.
Can you, I'm not familiar with that, the fees on the insurance companies and the fully insured products and whatnot. Can you just talk a little bit more about that?
Yeah, so in the Affordable Care Act, there was one of the financing mechanisms for the entire law was essentially just like a premium tax, and it was pretty broadly applied. And that went away I think it was at like the very end of 2019. And so our state kind of had a similar fee in place for health insurers, and the state just increased that to account for the carriers. So it is a tax on the underlying premium, but then we're turning around with these programs and putting the money back in, focused on these. Part of the reason that our legislature decided to do that was that there was concern that those savings wouldn't necessarily get passed back to consumers, and so they wanted to kind of have it tied to these programs that would guarantee that not only it would get back to consumers, but in a way that actually would reduce premiums and out-of-pocket costs directly that go beyond the current ACA.
Have you done any research into seeing whether there has been an impact outside the individual market on group plans as a result of that tax?
From year to year, the total tax collected looked to be about the same as it was under the federal tax. So for that purpose, it was about the same. One thing that we've done for our small group, and I'll say the tax amount was 2.75% of premium. So that gets levied on the small group, but then we're turning around with the program and actually providing a 10% premium reduction. So on net, that program is actually saving those small businesses money, even with the tax applied.
Yeah. I will jump in, and I know I'm watching time because there's a hard stop, so also interrupt me if anyone else has any pressing questions. But just on that point about the small group program, I did want to touch on it, Colin. I know that's a challenging market. Like it harkens back to your comments earlier on about looking for opportunities where there's, federal programs to leverage or flexibility. The small group market is definitely one that there just isn't as much maybe policy innovation in or opportunities to tap into those federal resources. I did notice in reading through the report that you it sounded like struggled a little bit with, especially mid-year premium increases, in that market, and that being a challenge with a model where you're, providing sort of a flat, percent, premium reduction. So was just curious. I know there was some note in there about thinking about other models and something you maybe grappled with, and wondered if there are different models you're thinking about, or kind of how you approach that. Because again, it's a tricky one, and definitely one that we're interested here in Maine and in making a difference as well.
Yeah, and I'll say we actually started this originally. It was going to be a reinsurance program, and that wound up getting really, really complicated because of the quarterly premium increases and how you keep track of that and when it would start and who it applied to. And it became clear to us that operationally, to be able to deliver the same thing we were attempting to do with that, which was just an across the market 10% premium reduction, we could do it in a more straightforward manner, just by applying it directly to the premium. So we are exploring some other ways of looking at this program. We're keeping it constant for now because small businesses are happy with how it's working. We've kind of updated how we do our budget requests on this to account for the possibility of premium increases halfway through our fiscal year. So we've kind of just had to do some internal changes to how we do things. But we're going to start having discussions with our carriers and small businesses about whether there might be other approaches to doing this, including having some way for an employer to carry that credit over if they're going to offer an ICRA in the individual market, something along those lines. And obviously that something like that could destabilize things on one side or the other. So we need to be very intentional about how we're moving forward with programs like that, but it's something we've been talking about internally, and I think within the next few years, we'll probably have some program changes to account for that.
2 minutes, 1 minute left at this point. I want to make sure we let you go on time. So I guess I just asked, like, anything I didn't ask about that you want to share? I'm sorry we didn't really get time to dig into Medicaid Forward, but maybe at a future meeting we can chat more about that. But yeah, any last words for us? And just want to say thank you again for joining.
Oh, yeah, of course. No, I think it's exciting that your state has set up this advisory council, and it's a model we're very interested in looking at more too, because it's a great way to get a lot of stakeholders around the table to develop policies over time. I guess I'll say, the legislature kind of looks to us to do research on other policy ideas, and advocates came to us with the Medicaid Forward idea, and we did a study with the Urban Institute on it that had some really promising results. It would really be a sea change here, so there's additional study happening about those kind of ripple effects that might have, but in terms of access to care and affordability, really looks to be something that would be promising, and I'd be happy to come back and provide a presentation directly on that in the future if it would be useful for you all. But otherwise, just would like to say that any way that we can be in constant dialogue with you all as states are really thinking about different approaches to affordability, not only in just that consumer side cost, which has been here at OSI one of our main focuses, but those systemic level costs and how we really get at those cost drivers. I think states have a lot of different ways of addressing that, and it's an exciting space to be in. So hope the dialogue can continue and we can learn from you all as well.
Awesome. Thank you again so much. I think New Mexico is such a inspiration in terms of the creativity of the work that you're doing and the connection to people who are going to be impacted. So would love to stay in touch and really appreciate your time.
Great. Thank you all.
Thanks, Colleen.
Take care.
The time flies when you're having fun.
So just at a real basic level, the healthcare affordability fund, Was that what he was saying was funded through that taxes that
Yeah.
continued?
Yeah.
Okay.
Yeah, I think that's kind of the term that they used for the whole pool of funding, or at least the pool of funding that was allocated to the office of the superintendent. Because one thing I was noticing reading through that report is they have these affordability programs, but they also have a little bit of that funding that they dedicated to research activities. So I think that that was part of how they were able to do things like a survey and
Right.
the global budget study, you know, that they kind of have this piece of revenue. Yeah, yeah, exactly what you're not.
My recollection is over $100 million, like what it would have been in Maine.
If we continued it.
Correct.
Wow.
I could, again, this is now like, you know, me remembering 5 years ago, but it was a substantial amount of money.
Question is, the premiums
Go down by
go down?
3%. Yeah.
But
Really interesting. I mean, it's certainly, I should have noted that up front. I actually thought when I sent around the report, I was saying like, make sure you read this one little section. Because obviously the big question is, you know, where that revenue comes from it. I think it puts New Mexico in a really different position than they sort of have this funding. We're deciding how to spend it.
it's like Massachusetts,
Yeah.
and they have their own compensating people.
Right. But it does sound like those paying the taxes are actually paying less overall.
Yeah,
Right, like
10%
still.
reduction.
Right, they're paying a tax, but they're getting more members, they're getting
more
the
money
benefit.
back in the sense,
Yeah.
yeah, so it's actually a net gain to them.
I'd be willing to bet that we talk to the insurance carriers, they may have, or the large employers may, it would be worth hearing the other side of that.
Yeah, I don't want to oversimplify. I was keeping an eye on the screen, wondering if Kevin would, you know, raise his hand, but I do think it is, you know, that there was a continuation there. And I think in general, sort of a reduction, because I could be wrong about this, but I think the hit taxes, I think they called it at the federal level, apply to large employers too. So I think that it was eliminated for them and just sustained for the fully insured.
Right.
Just continue it,
Right.
as opposed to now trying to set it back up again. It's a very different
Right.
Yeah,
political
it's a big lift.
capacity.
And definitely, yeah, the big star next to some of what New Mexico has been doing. It's still interesting to learn about, especially against like the technical.
I mean, it is doable.
Yeah, I like that idea. My only problem with it really is it doesn't address the underlying drivers of cost within the system. It just finds a way to pay for the same
It
system.
makes it
that's-
more accessible to the consumer in a way as well.
Yeah.
So it would reduce uncompensated care costs.
Yeah.
And they talk about that
Yeah.
these are all the savings from it to the state because of the uncompensated and all those things.
And I think I saw Trish's hand up, so maybe back down, but I want to make sure you get a chance to weigh in, Trish, because I know you had your hand up when we kind of transitioned into that session, but just briefly on that point, and I don't want to speak for New Mexico, so again, we could definitely have Colin come back and speak to this, but I think they would maybe argue that that might be part of the thinking about like a transition to something like the Medicaid forward model, where it is this sort of like much more comprehensive approach that's raising reimbursement for one group while lowering it for another and sort of bringing everyone onto not everyone, but the state regulated folks onto like a more similar playing field. So I think that they kind of acknowledge that and that they just felt a real desire to do something at the consumer level initially, but I think that they're thinking about those questions in the longer term too. Trish, did you have a question or did you want to weigh in? I want to kind of make sure we can transition back and have the Q&A and discussion.
Well, yeah,
kind of brains processing.
I'd like to, I just want to follow up on Trevor's point that I think the key, you know, lots of these things are really interesting, but they just are subsidizing the current system. And so where do we, and I think the question before us is how do we get at the underlying costs? And I'd like, Maureen gave us an incredible amount of information in record time. I'd like to, I'm very intrigued by the work on consolidation and hospital costs, and would just, if Maureen could maybe, where do we, is there any evidence yet that we're really having some kind of impact on hospital costs in any of these state initiatives?
Trish,
Uh,
I want to answer your question differently. I think it's still a little bit too soon, to be honest with you. So I'll give a very explicit answer. Texas actually passed some provisions to ban anti-competitive contracting, and their employer groups really led that initiative. And again, they did that in the 2022-2023 legislative session. They recently reached out and said, we haven't seen lower prices yet. What's happening? I mean, the problem is now that those provisions are no longer allowed, they have to go back to the table and negotiate without those provisions. And so I do believe they're setting this stage for that better negotiation, but that piece hasn't happened yet. So, I mean, as I think everybody around this table, and Trish, you know better than I do, as you address consolidation, it's trying to sort of create a more level playing field for everybody to have negotiation, and then that negotiation has to then happen. But I will say some of the things that we've also seen in consolidation, and again, I know this is related to affordability and this is a bit of an aside, but we've seen in other states some private equity dollars coming in, changing things and diminishing access to very key service lines. And so some states are looking at consolidation and trying to better understand what's happening with the ownership of different entities and who has voice at those tables to ensure access and not even necessarily yet to address cost. So just the fact that all of these things play very closely together.
Thanks.
I
You can
think
go
she does,
ahead.
yeah.
Mine's not coming out, so you go ahead. Oh, okay. I, when we look at hospital costs, and I'm not, hospitals should be looked at as well as every other segment of the system, including insurers' costs, as well as pharmaceutical costs, et cetera. But when we look at hospital costs, I hope certainly for Maine, first of all, one size does not fit all. And so that's an important element in terms of what health systems look like, how they're structured and how they're funded in different states. And I would hope that we would be looking at the whole picture, that it's not just about hospitals, but it's about physician practices, behavioral health, long-term care, the whole continuum of services that fall under the rubric of healthcare delivery system.
I think, I know Kate had a question and I see Jeff's hand up too. I wonder, just because it follows on that thread a little bit, I might chime in with one and then hand it to you guys. Maureen, you mentioned global budgets as something that states are looking at. And I think there's probably some folks in the group who are really familiar with that concept, but others might not know, especially since it is still only a few states that are experimenting there. I was wondering if you could just give like a quick little bit of a 101 about that model and sort of maybe a little bit about like how a Maryland model differs from Pennsylvania. I know they have some different outcomes. I do think it's an interesting model to think about and one that's emerging and more states are talking about. So I thought that would be worth just spending a few extra minutes on so folks could kind of get an introduction.
Sure. So one of the reasons why this is on everyone's minds is because the federal government through CMS, their innovation center, has put out a new model. And what's happening with that is that the Innovation Center is saying we'll accept up to 8 states to apply to participate in this new model that includes some changes to how delivery is done and how payment is done. And why a state would do this versus going on their own is that the federal government is going to come in and make changes to how Medicare pays for some of these things in that state, in the areas that are affected by the model. And there are multiple pieces of this. So it includes a hospital global budget. It includes investment in primary care. It is requiring states to have a health equity plan. It requires hospitals to have a health equity plan. And then it also requires states to have a total cost of care some sort of mechanism to measure a total cost of care and expenditures to ensure that costs do not rise as a result of this model. And Medicare has some very explicit savings that they that a state needs to show for participating in this model. So the idea is that you would create a global budget that provides some level of sustainability and reduces the focus on utilization for driving payment. So right now, and I know there are bundled payments, I know there's lots of different ways to do this, but most of those rest on a fee-for-service utilization-based mechanism where somebody goes in to see the physician, they get a service, and then a charge follows from that service. And instead, this would be, we are giving the hospital a budget with some expectations for quality metrics, for expectations related to services that will be provided and a population that will be cared for. And a hospital would have to stay within that budget, but also be assured to get that budget. And I'll just say during COVID, it was one of the things that really helped Maryland. Now, Maryland has rate setting attached to this. The states that are pursuing this are not looking to do a rate setting model like Maryland. It would look different. But Maryland was able to, while other states, when utilization went down for non-emergent services, people were having to lay off nurses or furlough workers. Maryland didn't have to do that. They were able to simply adjust some of their I don't want to say they adjusted their budget, but they were assured the hospital would get the budget that they were getting. They could keep people employed. And then as people came back and a number of hospitals were rushing to bring back on staff, Maryland didn't have those issues. Pennsylvania, this was done specifically for rural hospitals, and the goal is different for rural hospitals. The goal is really sustainability, and there's just not the population in rural areas to really help hospitals sustain on a fee-for-service basis in many areas. And so the idea is you provide it doesn't even have to be prospective, but ideally a prospective global budget where there's some level of sustainability and some predictability in what a hospital is going to be paid, regardless of how many services they provide to ensure people's health. And you tie this to quality metrics and health outcomes. And so there is increased interest across many states to look at this model. I will say the model that CMMI has put forward is complicated. It's very involved. It's not necessarily for every state. I would not suggest every state look at this. And NASHP is in a position, actually, through some funding we have, to help support states in applying for this. But some of those initial conversations are, what is the infrastructure you're working from before we even start down this path? So even setting up the total cost of care mechanism to ensure that you can track that spending, extremely important. And so I'll just say it's not for everybody, but it has sparked new conversation about moving away from fee-for-service and being more thoughtful in capitated payments and focusing those payments on outcomes versus utilization.
What's been the reaction from hospitals and states that have pursued this? I mean, on one hand, I would think they would be opposed to someone setting their budget, but on the other, there's so many headaches dealing with carriers and so much additional cost and getting claims paid that maybe they would be receptive or even like happy to have a global budget. So I'm just curious what the experience has been.
And I think I'm not the perfect person to answer that question, but I will say we have had conversations at NASHP with some health systems that are very pro this model for the exact reason that you just noted. They have, and again, I'm not speaking for all, it has been relatively few, but they have said, like, we want to move towards alternative payment. We want to move away from and in some cases, it's because some of the hospitals or some of the provider offices that are part of their system, they feel are not paid adequately on a fee-for-service basis, and they are hoping that the budget can adjust some of that. And then there's other health systems that are questioning whether this is something that they should be involved in. And I don't know that it's even the budget that's the issue, more the Medicare savings that have to be accrued within this model that is making some hospitals skeptical. So I'll just say that there's lots of different questions related to this. And from a NASHP perspective, as states are looking at this, even outside of the model, I think there's different considerations you have to take. But I wouldn't focus just on the states that are applying to this model, because there are other pieces to it other than the global budget. But to your point, Trevor, there are hospitals that are signing letters of intent to ensure that their states can apply, but that in no way means that they're obligated to participate as they work through the budgeting process. So they are signing on to participate in the discussion, not necessarily signing on to say this is absolutely totally what we're doing.
You know, just offhand where Maine is and when the deadline is for applying?
I can take that one. Well, you can do deadline maybe, Maureen, but I'm happy to maybe speak to Maine a little bit.
Perfect. No, that's perfect. I was going to say, I don't feel comfortable speaking to which states are doing what, just because there are so many different considerations that go into this. But the next so there was an application period already. There are 3 different cohorts that CMS has put out there for this model. Cohorts 1 and 2 have had to apply already. That application was due, I believe, March 18th. And I know there were some states that have applied. And I know that there are some states that are looking to participate in cohort 3, and those states need to apply by mid-August.
And just on the main piece, state lead agencies have to be the Medicaid agency for applications, because it is a multi-payer model and needs to be built on sort of existing Medicaid payment programs for primary care. There's sort of an infrastructure need. So I know folks there have been engaging with this and talking with others around the state. And I don't think they've made a final decision. I do think that some of the questions around the budgeting piece and the complexity of the formula that came out a little bit later than folks wanted have been a bit of a challenge. But definitely looking at it, and then I am going to hand it to Jeff first, sorry, just because I have the feeling he might be kind of continuing on this thread, and then we'll hand it to Kate. But I will say a takeaway for me in participating in some of the, webinars on this and talking to other states is the degree of infrastructure that they have around these kind of payment models. I think our Medicaid program has obviously been really involved and has strong relationships, but we haven't, I don't think historically had as much sort of engagement with commercial payers and talking about that component. So that's been a learning and something that I've been increasingly thinking about as, maybe something that this office, this group could play a role in, is figuring out, are there ways that we can be talking so we're not responding immediately when a CMS model comes out, but trying to vision a little bit more for ourselves and maybe even go to CMS and tell them what we would like to see. So something that's been kind of brought to the forefront, I think, because of a head. Sorry, Jeff, I know you've had your hand up for a bit. And like I said, you may have more to say on this than I do, so I wanted to pass it off to you.
Yeah, no, thanks, Meg, and thanks, Maureen. Just a couple things. I think Maureen's comments on, this is a model that is not for the faint of heart. This is really, really significant, and we've sat in and participated in many of the webinars. They brought in the folks from Maryland, the folks from Pennsylvania. We had some discussions with Vermont One as well, and we've read the model around the hospital global budgets, and this is really going to be a big lift for any state that gets involved in it. I will share that Lisa Letourneau and the folks at Maine Care reached out to the health systems. I know ours, I'm sure Maine Health as well, reached out to the health systems, had some discussions with us, had some surveys filled out, what our level of interest was, and did some follow-up interviews as well. So I think, a lot of stakeholder engagement, from the state on this. I don't know if they've applied or if they're going to apply. I'm kind of interested in finding out. we've been sort of keeping our finger on the pulse. But at the same time, we're not going to get, over our skis on this until we know, Maine is in. If Maine is in, then, we really ramp up our analysis of how, we could engage, through this particular model. I think it was also mentioned, maybe Meg, you mentioned it, maybe Maureen, but CMMI has tried a number of multi-payer models, and generally they end up not being multi-payer. And that is going to be a significant issue for us. When we talk about population health, we talk about, feet in two canoes. Kind of tired of having feet in two canoes. We're not going to have half a global budget model. That's probably not going to work for us. So, if we don't get over that sort of critical mass, I'll say, in terms of multi-payer engagement, I just feel like it's probably not going to work. But we'll see. We got to wait to see who makes, the 8 states, right? And then we can have some more discussions about that. But I will say it's an interesting model, and it will significantly change the way a state and the providers in that state view healthcare. It is instantaneous population health at the max. And I did have another question, Meg, when we get to it, so.
Okay, perfect. Christy, did you want to continue on this thread, or was there something else that you wanted to bring up?
I have a quick thought as a person who works at a provider and also as a patient of a rural healthcare system. And through my window, I can see our nursing home in Presque Isle, which will be closing in 60 days. It will be really nice. I don't know how set our agenda is for future meetings, but it would be very interesting for me to hear from a health system that had experience with this global budget exercise and what their real experience, pro and con, was with it.
Yeah, that's a great one. Happy to note that down. Okay, I will then hand it to Kate, and then we'll come back to you, Jeff, if you had something on a different topic.
Quickly, just because we were talking about health insurance assessment before, I did look it up, and at the time it was discontinued. It looked like it was about 35.5 million in Maine that we were estimating. But anyways, my question for Maureen was, and I can't remember which state it was, it might have been Oregon, but you're talking about looking at like the health of the overall market and different partnerships, not just mergers, but between entities. And I was just wondering if you could talk a little bit more about what that looks like, particularly because at least in Maine, and I imagine to be elsewhere, like what does the state have access to in terms of like contract arrangements? Like how would you assess those different types of relationships and partnerships?
Sure. So it gets really weedy really fast, and I will admit that I don't know all the ins and outs of it. So I'll just say that. But I will say Oregon has a lot of public information on their website that is incredibly helpful. So this is being done. This was created in I believe, 2020 law or 2021. And it is in effect, they are implementing it. The law creates an office in their Office of Healthcare Authority, which includes their oversight of Medicaid. It includes their state employee health plan, their public employee health plan, so teachers, other folks. And so this is sort of a large agency. They have a lot of data infrastructure already. And then this office was created. It's small staff, but they have some mechanism to bring in contractors as needed for large reviews. And they have a definition of what that means. But the law gives them something that other states have been asking NASHB about, but others don't have. So there is a notification requirement. Some of the issues that states have raised is they don't know when these kinds of transactions across providers happen. So one, they have to be notified, and there is a threshold. I believe it's a monetary threshold of notification when there is, and again, this falls well under the federal FTC regulations. And it's not just a merger, it's not just an acquisition, it is a transaction. So what they have done is like exempt things like if a provider entity wants to get a new MRI machine, like they don't want to have to review those things. But if there's going to be a new contract or a new investment of funds, and again, it's been prioritized that private equity is something that they can review. If there's going to be a new infusion of funds that changes not even necessarily ownership, but decision making for a health system, a hospital or provider office, that they are able to review that. There is very detailed rulemaking that they went through about what they can collect in order to do these reviews. There is some privacy references. Not everything is shared with everybody, but the state has access to certain documents, certain contracts. And then the state is able to approve, deny, or approve with some level of condition for some of these transactions. And they publicly have shared what they've reviewed. They don't review everything. And what they've approved, I don't believe there have been any denials yet, and what the conditions are. So it's all on their Office of Health, I believe it's Health Market Oversight within the Office of Healthcare Authority.
Thank you. Hey, Jeff, if you had another question or something else you wanted to follow up on, do you want to go next?
Yeah, I want to go way back in time and talk about upper payment limit, upper price limit, upper payment limit. So, sort of thinking about that mechanism, how does, so setting an upper payment limit on a particular pharmaceutical, how does that eventually get back to big pharma? Like, isn't the pain borne by the retail pharmacy and maybe the PBM, or the wholesaler? I mean, how does that influence them, right? As opposed to, taking it out on the, whether it's a retail pharmacy or whether it's, something that ends up being inside of a physician practice that administers a drug in a particular practice. That's the part that I don't see how that connects back to the ultimate price setter, which would be which again would be pharmacy.
Yeah, so I can take the beginning of this and just say that your question is perfect. And that's what states that have this authority, and there are a few states that have it right now. So it is Colorado, Maryland has it, and Washington does. There are more drug affordability review boards. Fewer have this ability to set an upper payment limit, and no one has done it yet. So we are still in learning mode. And there are these exact discussions. And again, I don't want to share which states are wrestling with what, because they really are still wrestling with it. But it is exactly what you just noted. There is a whole drug supply chain, and the manufacturer is ultimately, I'm going to go out on a limb and say, where we want the lower financial, we want them to be the ones that ultimately experience this. And then through the drug supply chain, the patient then gets the benefit of having this upper payment limit be lower. The patient gets that benefit through their out-of-pocket costs and also through their premiums. This is the idea. Now, how that's going to be felt in practice, we are still trying to find out. So one of the states that has this upper payment limit authority is Washington. Washington is being more thoughtful and iterative in how they're moving through this. They just passed some very comprehensive PBM regulations and restrictions that are truly extremely new, but they did that as a way to help their prescription drug review board be able to ensure some of these upper payment limits could be felt, and there could be transparency through the supply chain about how that's going to hit a pharmacy, how that would hit a health plan, how that would hit a provider. And so I wish I had a better answer to the question. I'm not trying to be evasive. It's just exactly what Colorado in their rulemaking right now is wrestling with, and what Maryland, who has upper payment limit authority only for their public payers, is also wrestling with. And I think different states will end up setting rulemaking on how this works slightly differently, given the different goals that they have. Again, Maryland's trying to save the state money through their public purchasers as well as their employees. And then Colorado with a very specific interest in helping consumers experience this savings. And so how that's going to affect where the upper payment limit hits the drug supply chain, I think will be slightly different in different states.
Not seeing any other immediate questions. I'm just amazed we're hitting timelines perfectly today. It's right about 4 p.m. I wanted to just bring up sort of next steps and have a conversation about that. I admittedly struggle with how to organize thinking about such a broad topic and so many potential possibilities. So I had a few ideas for how we could move forward in the next few meetings and wanted to get the group's thoughts. I think there's definitely more to learn from other states, and I've heard a few people say, could we, hear more about that? So I think one way would be if we just want to go through, and I've written down a few, but I could also kind of poll the group afterwards and say, are there a few other models or states that we really want to, hear from, and just do a similar kind of conversation, do some read ahead, ask some questions, sort of approach it that way. And again, just truly a learning exercise and an information gathering exercise. I guess I'll split that into two, one being if we want to be really specific about certain policy interventions and do it that way, or I know Maureen mentioned, Colorado and Oregon as a couple of states that are really doing a lot in this area and approaching it. We could also ask maybe somebody from one of or both of those states to come and talk about kind of their whole agenda. So a couple options there. The other path forward for me is trying to think about like bringing a conversation about this prioritization piece, and whether I don't know that we're at the point of getting to making those decisions right away, or if it's more like really laying out, is there a framework that we want to go through to think about how we kind of, again, talk about these affordability dimensions. But my sense is I found this informative, and like I feel like my wheels are turning a little bit more, and that doing a little bit more learning from other states, at least in the next 2 months maybe, and then kind of revisiting the question, in part because that'll also give us a little bit of time to continue working with MHDO and come back with some of the additional data analysis that we've been trying to do. It would maybe be my preference, but I just wanted to get a sense from the group, or if others have a different way of trying to work towards how do we begin sort of structuring these questions for ourselves and figuring out a way to kind of, discuss pros and cons of different options. I would welcome the input on this one. A lot of ground to cover. Yeah, Katie?
There is a lot of ground covered, and I appreciate the way you're thinking about it, Meg. I think it never hurts to learn as much as we can from other places. When you think about a framework, though, I like the idea of putting together a framework, because every state, certainly every region is different. So those things that are driving costs in Colorado may be quite different than those things that are driving costs in Maine.
Yeah.
And I would want to make sure that that we are looking at the whatever states or whatever options that they're adopting within the framework or the lens of what's driving cost in Maine.
Yeah.
And that to me is just a really important point, because we've seen this one size fits all approach that would impact us quite differently than it might impact other states. And conversely, there's probably things that we can do to address costs that may not impact a Colorado or a Washington State or Oregon. So just trying to make sure we're.
I think increasingly I almost think of like parallel tracks. I think the challenge is increasingly, it's like, I don't think we're ever going to put a pen down on analysis and like answering questions and necessarily get to a place where we're like, we understand our whole health system, we know exactly the problems. So how do we continue making progress on that, but like also feel like maybe at least we have a sense of the options that are out there. So at some point, those two things can kind of converge and starting the conversation about policy at that point.
I mean, I think the Medicaid forward looked really interesting, so I think that I would be interested in learning more about. Well,
Great. I'll briefly just go through because I was trying to note down when people were raising interest and then I see Tricia's hand is up, but just so folks know, I captured it and in case anyone had any, because I think if we want to go that direction, maybe what I could do is put a quick poll together and say like, here are the different ideas. Are there some that have consensus on being highest priority? And that was on global budgets, hearing specifically from a health system that's participated if we can. A little bit of a tougher order. I might have to ask some folks for help with that, but I think we can look into it and see if anyone would be willing. Medicaid Forward was on my list. The Oregon model for kind of market transactions and infrastructure review was another. I think that's what I had. So I'll pause there. Others can think about if there's others. Oh,
Go ahead.
Okay.
I think she was next. Yeah.
Thanks. Yeah, I just wanted to get to you, Trish. Did you have thoughts?
I think that's a great idea. I'm sort of intrigued by Colorado, but recognize Katie's point that Colorado is a younger state than we are. And what drives, what the cost drivers are is important. But I'd also point out that some of the cost drivers don't show up in the data. We know from the national studies that hospital and health system consolidation drives prices up. But we don't know if that's the case in Maine, I don't think. And I wonder, Maureen, is there a way to find that out? I'm thinking of Erin Fusé-Brown's work, and has anybody looked at a state like Maine? Or is there a method that we could look at?
The quick answer is I don't think there has been a focus. So I'm thinking of Maine as, yes, an older state, but also a smaller state, and also recognizing where we're situated in New England, which is also kind of a challenge. But I don't know of something off the shelves that is very easy to give you that answer. But Erin Fusé-Brown, who is actually going to Brown University. She's leaving Georgia State University. Yeah, and she's going to Brown, where she's going to join a team that is being led up by Chris Whaley, formerly of RAND. And so I would encourage you to think about them. They really are looking at this from a health plan all the way through, because as we know, consolidation is not just at the hospital and provider level, it is broader. And so to really understand it, but I would put a plug in for them.
Sounds great to me.
Yeah. I would just on the New Mexico Medicaid Forward thing. Are there other states that have sort of Medicaid buy-ins that we could look at as well, or that are doing it or planning on doing it? That I'd be curious.
I have typically thought of New Mexico as definitely a leader on that. They've explored some different models of a Medicaid buy-in in the past before coming around to this model. I would have to refresh my memory. I do, and Maureen might remember more. I think a few other states have done a study of it. I know other states have expressed some interest, but I'm not sure any have gotten as far as sort of like building out that detailed of a model. But I can revisit that if there's interest.
that sounds right. I mean, some other states have done basic health plans, which are different, but like still offer low cost sharing times for different income groups, but not really the same as the buy.
See Maureen nodding, so I think we have her. I'm not
Yeah,
forgetting all these ones there, Maureen.
Yeah, I will just say, like, it was a hot topic for a little while, and then very few states actually pursued anything. And to Kate's point, the basic health program has got a little bit of new legs after not having a strong focus for a while. So Minnesota has it, New York has it, but Oregon is pursuing it. I believe Kentucky is looking into doing it, and New York just got a new waiver to infuse some additional funds into theirs to do something new through, I believe, a 1332. Not to get too weedy, but just I don't know if there's a lot of states with Medicaid buy-ins, but there is increased interest in the basic health program. Anyway.
Two quick thoughts. One is, no one's mentioned Vermont, which was a leader early in this whole space, and I'm curious about that and what may or may not have worked in Vermont. So that, because that is a very similar population to me. From a rurality and income level.
So for them not not as much a single program update, but just what is the status of things to go on.
Yeah, what happened? Yeah, I mean, they have a whole process related, they have to through a budgeting process and so that would seem important and I'm super curious as to why no one's mentioning them. But the other thing that I would ask, I am not in any way opposed to looking at the impact of consolidation. I hope when we do that, if we look at it specifically to Maine, it's not about hospital consolidation. It is about the formation of health systems to support access to care for the rural communities in which we live. It's so if there's a balance there between driving up costs, so it may be that costs are higher because practices were all going under and there was not going to be any access in rural communities. So it just needs to be looked at in a balanced way, which many of the studies, including Aaron Fuse Brown, have not done. And they've been very specific about hospitals. So that's super important to me as we look at this.
Yeah, consolidation, I see what you mean across sort of different service types. And
Behavioral health, I mean, we're losing consolidation behavioral health. The state is funding it right now because we're about to lose a behavioral health provider in the state. So we've got to be honest about the impact of the rural nature of our state, the elderly nature of our state, and the poor nature of our state, and the poor
And
healthcare.
And the intergenerational substance use / mental
Health status.
Yeah.
yeah, I will say, definitely well taken. I think a factor in that is the challenges in like data collection and monitoring. You know, I think some of that absence isn't that folks are intentionally, trying to not include that, but that it's so much harder to find data sources to have like a comprehensive picture over time of something as complex as those kinds of changes and shifts. So I totally hear you. It's the piece about how we accomplish that I think is
There, if we're looking at this sort of, that it seems very important that we look at all aspects.
Yep. Trish, I saw your hand is up. I wanted to double check if it was okay.
No, I just forgot to take it down. Sorry.
No problem. So I think, and definitely welcome more thoughts. If folks want to maybe, if you're mulling, email me by the end of the week with other thoughts. And then I'll put a little poll together and folks can kind of maybe rank just as a way to help me prioritize these. I think I wanted to ask one other question about format, and this was an idea I'll give Trevor credit for. Wondering if folks want to do this in these meetings at a time when we can all be together, or, if we could do sort of some interim gatherings. I will say, given the challenge of finding time for this group to gather, I don't think we'll be able to do that in a way that can like accommodate all schedules. But we could, just land a time and sort of have folks attend if they can and record it and share the sessions and then use the bigger gatherings for more discussion. That makes sense.
That's a great.
Thank you, Trevor, for the idea.
And with chat GBT, and give us the minutes, nobody has to take them.
If only, yeah.
Fathom note taker, I'm like,
I can try that one.
oh, it is amazing.
I'm sure that there is some directive that I am not allowed to use. It's funny, I was like, okay, great. Are there any other sort of questions, points of discussion that anyone wants?
We hope that you get a hire soon.
Very close. I was sharing with Katie before that I'm hoping that we are close. I hope I could come to this meeting and maybe share an announcement, but if everyone can cross your fingers for me, it would be much appreciated. And definitely, hopefully by June.
And I do want to say publicly that what I said to you before, which is I thought you did a really nice job with the workforce.
Oh, thank you very much. Yes, I should mention too, I know, I maybe leave it up to the group. Yeah, it was fun. I was saying, it's a really fun topic to delve in on and a lot to cover. I did very briefly speak to the legislature on my very last minute last week, and I think I shared in my email, they have enough going on. They sort of said, come back and present this at the start of the next legislature. So I think in terms of next steps, certainly I'm sure some legislators may want to engage on that. I welcome kind of having a conversation about the report as part of this group, it feels like if we're bringing, Medicaid forward and then talking about BHP, that's a little bit of a natural iteration. So I can put it on as an agenda item for the next meeting, or we can just kind of use the exploration, I think, of other states' approaches as a next step on that, whatever the group would prefer.
That's a totally off-topic conversation from earlier in Maureen's presentation. I just had noted to myself. You had mentioned that some states are pursuing plans with zero cost sharing for chronic conditions like diabetes and cardiovascular disease. Have they been tracking what the impact on total cost of care is from those plan designs? Do they know if they're having an impact?
So it's in where it started is Massachusetts. The other leading state is California. They are doing this through their state-based marketplaces. And I will just add that most of the people that are benefiting from this are getting the federal subsidy to help with their premiums. So as the cost sharing is reduced, the goal is to reduce the cost sharing. I think that there is an increase for some of these plans on their premium side, but because there is a federal subsidy that helps balance that out for the people that are benefiting from it, the state's focus really is ensuring access. So I'm not suggesting that this is something that employers can easily do. I'm just sharing it as an affordability mechanism that some states are pursuing for a portion of their market. Does that help?
Well, and I noticed in the New Mexico, with part of the new thing is mental health has no cost sharing. They carved that
But
out.
it should reduce inpatient.
One would
You think, right? Intuitively, it makes a lot of sense.
Curious to see, yeah.
Yeah. And hopefully I'm not misspeaking here, but just to see, I think Kevin may have needed to sign off, but my recollection is I thought CHO for some time had
They do.
a diabetes specific,
Yeah.
so I actually wondered.
Diabetes, hypertension, there's 4 conditions, I think, asthma.
So,
But they-
yeah, their team might have some
Yeah, yeah.
longitudinal data in
Yeah,
terms of
that's
like
really interesting.
impact on the
I'm
patient.
curious to see.
It's not in all of their plans, but.
Yeah.
Yeah, it's sort of like a specifically marketed plan for certain people.
You know, one other thing that I was struck again by this data fact the other day, and I've tried to dive into it and figure out what it is. So Maine, it is constantly cited as having the highest per capita cost of mental health or behavioral health care in the nation for states. But I can't figure out exactly what the drivers of that are. And I think that's a big piece when we're talking affordability, costs and everything. My sense from what I was able to find when I dove into this before, like 2 years ago, and I just saw it again referenced in an article. And I was like, where did you get that? They didn't really cite where, just that Maine is known. But I think that would be an important thing for us to understand. My understanding is that we count behavioral health and mental health care differently than many states, and maybe even wrap in our correctional costs of it that other states don't do. But I'd be curious if that's something that one of these folks that you work with or somebody would have more access to that information of what, because that's a big piece. Like that. If we're spending more per capita than any other state,
Right.
and we still have bad outcomes, what are we counting and what are we getting for it?
Yeah.
So,
I'm happy to try to take a look if you saw it somewhere and find and send me the link, just so I have kind of like a starting.
well, they
point.
didn't have, where it's not referenced again, they didn't have a link to anything. They just stated it as a fact, but I have seen it multiple places. And
I'll do some looking.
I think Kaiser Family Foundation actually references it as well.
I think our rate of, it's not just cost though, I think our rate of diagnosis of behavioral health issues is.
It is, I know.
And we see it in our
Yeah.
duals, we have a much higher percentage of dual,
Medicare, Medicaid, Medicaid.
And yeah, high prevalence.
It's sure, we do a better job at identifying.
Or
it.
something, yeah, but it's a factor that we should be thinking of if we're talking about cost and affordability and access and everything. I just was struck by that again in this article. I'm like, you're not giving me a link.
Yeah.
Where did you get
I
that?
know, that's a.
yeah.
Okay. Anything else? Otherwise, we can wrap up, let people hit the road and hopefully get home before too much
Yes.
snow or wind starts. I just want to end by saying thank you again to Maureen for coming and spending so much time sharing her incredible encyclopedic knowledge of what's happening in other states. We are so lucky to have her here in Maine. So just thank you again, Maureen, and I'm guessing we'll have follow-up for you. So it may not be the last you're seeing of us, but really, really appreciate you being willing to do this.
Well, thank you so much. And I so appreciate being able to sit in. It's so helpful to hear directly from a group like you all. And affordability is so important. I so appreciate you doing this. As a Maine resident, I so appreciate you guys doing this.
We're working on it. Yep. All right. Thanks again, everybody. Have a great rest of your day. Hope you see you
Thanks.
out tomorrow. Bye-bye.